We welcome you to today's webinar hosted by the Georgia Health Information Technology Extension Center. We ask that you connect with us at www.ga-hitec.org and via social media at Georgia-HITEC. Georgia-HITEC is Georgia's only federal and state endorsed expert to assist providers in the achievement of meaningful use of EHR technology. We are located at the Morehouse School of Medicine, National Center for Primary Care. And now a few housekeeping measures. As participants, your microphones are muted and shall remain muted through the duration of the presentation. We ask that you check your internet connection for an optimal video and audio experience. This icon can be found in the upper right corner of your screen. We ask that you refer all tech issues to the Tech Support Chat Pod, and we ask that you refer all presenter questions to the Presenter Q&A Pod. You are encouraged to submit your questions throughout the presentation, but there will be periodic stopping points for question and answer, and there will be time designated at the conclusion of the webinar for discussion, questions, and answers. I present to you today's webinar entitled MACRA Quality Payment, Advancing Care Information and Improvement Activities, moderated by Ms. Phoebe Nelms and Ms. Les Henson. In compliance with ACCME guidelines, the following presenters have no financial or other relationships with the manufacturers of any commercial service discussed in this educational activity. And now the objectives. To recognize advancing care information objectives and measures, to identify and review scoring for advancing care information and performance categories, to examine options for advancing care reporting using Certified EHR Technology, and to understand the focus of improvement activities as a vehicle to reward care coordination, patient engagement, and safety. And now Ms. Nelms.
Good morning. Well, good afternoon, everyone. We're so very glad that you could join us for this webinar on MACRA. Are you ready? You know, many physicians have responded favorably to the changes that MACRA proposes to make because it'll reduce the administrative burdens on physicians so they can focus on what they really love to do, which is take care of their patients. However, there is also apprehension on how smooth the transition to value-based payment models will be as CMS works to modernize the Medicare payment system. And as with any change, the best way to prepare for its impact is to become informed and to be prepared to participate in the program in a way that sets your practice up for success as the program evolves. Now, I've been really focused on MACRA, and because our audience is peppered with many medical people, I thought of some new diagnoses that are related to MACRA. There's macrodipsia, a thirst for understanding MACRA. You probably have this one if you're on this webinar. Then there's macrocephaly, MACRA on the brain. I think I have this one because I've spent a lot of time thinking and learning about MACRA. But for many of you, maybe you suffer from macrophobia. That's an inordinate fear of MACRA. Well, we really hope that this webinar helps reduce your symptoms because we want to provide you with very practical and useful information.
Okay, so this is interesting what we're seeing on your polling questions, because we see that 45% of you feel like you that you're not sure what's going on, but 26, at times there was 33% of you feel like you are up to speed and know you'll be eligible to participate. So that's pretty exciting that some of you have that confidence. Hopefully we'll just help you tweak that a little. Of course, we know that being up to speed on knowing what's required is not the same as knowing how to accomplish those requirements. And those are some things that we'll investigate today, and then we'll continue to work with you over the next year to achieve. Thank you for responding to those poll questions. So what is MACRA? The acronym MACRA stands for Medicare Access and CHIP Reauthorization Act of 2015. And of course, the CHIP Reauthorization Act is legislation that applies to children and Medicaid funding. So that's not really something that we address when we talk about MACRA, but it is all part of this quality payment initiative. MACRA is defined as a quality payment program where reimbursements are paid on quality rather than on volume, which is a major change for our providers. And this is for your Medicare reimbursements, and it impacts more than 600,000 eligible clinicians. So just to recap on that, MACRA the legislation impacts Medicare reimbursement, but we do firmly believe that we will see and have already seen some of your commercial payors migrate to this type of payment system, and indeed some of them already have. MACRA establishes new ways to pay physicians for caring for Medicare beneficiaries, and it also provides a path to value, and it does remove the fee-for-service reimbursement program that we've had for so many years. So what does MACRA do? Now, as we look at MACRA as a whole, it brings together some existing programs. Specifically, it brings together the PQRS program. Initially, we called it PQRI, then PQRS, but it's the Physician Quality Reporting Program. It combines the Meaningful Use Program, gives them different names, but it actually takes the components of what were meaningful use and puts those into a combined program. It takes the value-based modifier payment that was being used in the last several years and puts it into the program. And these three components for 2017 make up the merit-based incentive payment system, or MIPS. So this is kind of like with meaningful use. We told you just learn the acronym MU. So we will be seeing terms like MIPS and MACRA over and over and over again, and then we'll have some names for and acronyms for the components. So we just ask that you learn those acronyms and be familiar with what they mean, so when we work with you individually, you'll have some familiarity with what they are. So prior programs estimated a total penalty risk of 11% or more in 2019 or 2018. And the MIP, or the MIPS program, reduces the penalty of 4% maximum in 2019. So you do have a lessening of the penalty potential in 2019, and then of course that climbs over the next several years. And I believe you perhaps if you attended the previous presentation, you got more information on that.
So Liz, I'm back online. I'd be happy to pick back up. All right, thank you so much. So, as Liz mentioned, the Quality Payment Program has two alternate tracks, you could say, two paths. One is the alternate payment model, so that's one acronym we need to learn, APMs, and the other is MIPS, or the merit-based incentive payment model. And since we will be focusing on MIPS, is because it's estimated, as Liz said, that over 600,000 providers will be eligible to participate in this path, particularly in the topic of this webinar, which is the advancing care information component and the improvement activities. We want to be sure to provide the information that you need to be successful there. So there are 4 categories of performance areas where you will have to require a score, and we have the default weights listed here. And these weights can be adjusted in certain circumstances. And as mentioned, it moves Medicare Part B clinicians to a performance-based payment system and provides clinicians with the flexibility to choose the activities and measures that are most meaningful to their unique practice. And the reporting standards align with advanced payment models wherever possible. So we come to our second polling question. Which components of MIPS are you most concerned about? Is it number 1, the quality component, or 2, improvement activities, advancing care information, number 3, or cost? And thank you so much for submitting your responses. So it seems as if most of our viewers are most concerned about the quality component of MIPS, and so really glad to share with you the recorded webinar that we did previously that went into great detail about quality, which is housed on our website. So who will be eligible to participate in MIPS? MIPS eligible clinicians, of course, would take Medicare Part B, and they would bill more than $30,000 per year and care for more than 100 Medicare patients. So falling below these thresholds would make you ineligible to participate. And the types of physicians or providers who can participate are physicians, physician's assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetist. So, who would be included from MIPS aside from not meeting the threshold? Well, if you're a newly enrolled Medicare provider, if you're enrolled in Medicare for the first time during the performance period, you'll be exempt until the following performance year. And again, if you're below the threshold, the low volume threshold, less than 30,000 or fewer than 100 Medicare Part B patients, or if you are significantly participating in an advanced APM, receive 25% of Medicare payments or see 20% of Medicare patients through an advanced APM, then you would not be in the MIPS, on the MIPS track. So, you have the option, because CMS wants to give greater flexibility, to pick your pace. And so here are the options graphically illustrated. If you don't participate, well, you will receive a negative 4% payment adjustment. If you submit at least one quality measure or one improvement activity, then you will avoid the negative payment adjustment just by submitting something. If you submit 90 days worth of data, then you may earn a neutral or small positive payment adjustment for submitting data for a partial year. And you can also submit a full year of data where you may earn a moderate positive payment adjustment. So it is important to participate. And this allows, again, for increased flexibility while providers adapt to the program. And the positive payment adjustments are based on the performance data that you submit and on the performance information, not on the amount of information or the length of time that you submit data for. So what is the timeline? How does that impact your preparation? So the impact of what you do in 2017 begins in 2019. So in 2019, you can achieve up to 4% positive adjustments to your Medicare reimbursements, or you may be subject to a negative adjustment up to 4% based on what you do this year in 2017. And depending on your performance, your reimbursement will be adjusted accordingly. And what you report in 2018 will impact 2020 and so on. And your upper and lower limits could increase every year because you're scored against other providers. So this program is effective as of January 2017. That's when the performance period opens, and it closes December 31st, 2017. So you would care for your patients, record the data using your electronic health record, and you must send your performance data that you've collected this year by the deadline of March 31st in 2018. So there's also a flexible start date for data collection. Let's say you're not ready to start collecting data in January. The absolute last date that you can start collecting your data is October 2nd. It's the last 90-day period of 2017. So that gives you time to adjust and plan accordingly. So now we come to polling question 3. Are the 4 performance categories of MIPS equally weighed? And we look forward to your responses. So it really seems that CMS is working at responding to the feedback that they've gotten from the other programs that were in place and have incorporated the suggestions to make it more flexible and consolidated reporting. Okay, wonderful. Thank you so much for your responses. And now I'll turn it over to Liz to discuss advancing care information and how we can score in this category. Thank you.
Thank you, Phoebe. So as we look at advancing care information, which we'll call ACI, just because that's a mouthful to say, is the equivalent of what we in the past have called meaningful use. So it's not that new, it's not that different, it's just that you have a lot more flexibility with the ACI component than you did with meaningful use. And I know over the last several weeks, with the deadline on March 13th for Medicare meaningful use, we've had to tell a lot of providers, I know you only failed one small component that you only needed one of, but if you failed it, then it's done. It was an all or none. And the ACI component is not an all or none. So as you can see, it is weighted 25%, and we will note that these weights could change as time goes on, as we become better and more effective at utilizing our EHR technology. The advancing care information component may actually be lowered as a percentage of the overall score. And we didn't mention too much about cost, but in 2017, cost isn't an issue. I do want to tell you folks that when you look at these components, quality improvement activities, ACI, and cost, this is not as bad as it looks. And if I were concerned about any of the component, it would be the cost component, which we're absolutely not used to dealing with. So we will have some additional sessions on the cost component later in the year so that you can prepare for 2018. But for right now, we'll focus on the three that matter this year. So the ACI goals or components end and replace the Medicare EHR incentive program, which we knew is meaningful use. However, Medicaid meaningful use does remain. It promotes patient engagement and the electronic exchange of information, or HIE as we often call it, using Certified EHR Technology. And so there's more of a focus on that than there is, for example, CPOE or some of these other requirements that we've worked so hard for the last 6 years on. And it absolutely gives us greater flexibility in choosing which measures are best suited for the practice that we can achieve and that should be the best for our patients and for improving health care. So this just takes a little look at how meaningful use compares with the ACI component. So as we discussed, in meaningful use, you had to report on all objective and measure requirements, and if they were the MU requirements, you had to pass them. And there was a threshold that you had to meet. The ACI component streamlines the measures and emphasizes interoperability, information exchange, and the good old security measures. Clinical decision support and CPOE are no longer part of these requirements. One size fits all was the only option you had for meaningful use, where every measure had to be reported and had equal weight, even if it didn't have equal threshold. And when we look at equal weight, it was if you failed one, you failed the whole thing. So I guess that's equally weighted. For the ACI component, you can customize which measures you want to use and which measures you're scoring highest on. And as we begin to work with you folks on achieving MACRA and getting a high score, then one of the first things we're going to say is, let's look at your measures and see how you're doing on the ACI side. That's something we can look at right now today and make some decisions about how you can impact that number today. For meaningful use, as I've said, all or nothing for the measurement and the quality reporting. Although the quality reporting, we didn't have any thresholds. Again, flexibility on the ACI side, multiple paths to success. You can do poorly in some areas and do a great job in other areas and make up the difference, which was not something you could do with meaningful use. Meaningful use wasn't necessarily aligned with any other reporting programs. It was its own entity, and ACI is aligned with other reporting programs. As a matter of fact, you can get additional credits in the improvement activities, for example, if you utilize some of the components of your EHR, which you also use for the ACI requirements. So there is a better mesh and actually a better way to understand where this is all going and how this all works together. And sometimes we lose sight of what the end game is. So, the structure requirements. So this program, or this component, which is 25% of your total score, is structured to report for a full calendar year to maximize how much money you can get on the positive side. It aligns with reporting requirements for the categories, and the first performance period is January 1 to December 31, 2017. Now, that was the original proposed date range, and the full calendar year is the original proposed measure or attestation period. However, we all know that we have our some choice in whether we want to do a full year, for which I am very grateful. We're going to talk about that a little bit more. Clinicians must utilize a 2015 version of a certified EHR technology by 2018. So that's not an option, and that tells you that's something that your EHR companies have got to make happen by 2018. In 2017, clinicians may use the 2014 editions, which is what most of you have. Perhaps not all of you, but most of you have the 2014 edition, and you can submit modified measures, which we'll go over. Modified measures align with stage 2 of meaningful use. So we didn't get very far away from meaningful use, but we still have the flexibility and no thresholds. So 2017 is a transition year, and it's the year that you can pick your pace. And with that said, folks, we're going to encourage you to start looking at your data now. We feel that it may be easier. If you've been reporting for meaningful use, then you've already got scores in most of these categories, and maybe the goal will be to raise the score. So we want to encourage everybody to work on the full year for this particular component, realizing that at the last minute, if you can get a much higher score if you only use 90 days, then you can choose to do so. And of course, as we coach you on meeting these requirements and maximizing your reimbursement potential, we'll talk to you about these. In 2017, 2 measure set options are available. We have the original Advancing Care Information Objectives and Measures, and there are 15 of those. And then we have the option 2 that were brought about by the flexibility ruling, and that's the 2017 Advancing Care Information Transition Objectives and Measures. And there's only 11 of those. How do we know which ones we're going to pick? It's based on which EHR certification that you have. The option that you use to submit your data is purely based on a 2014 version or a 2015 version. Now, folks, many of you may be thinking, oh, we got an upgrade in 2015, so we must have the 2015 version. And that is probably not true. The 2015 version is an additional certification that your EHR company had to pay for and had to qualify for. And I can tell you that very few right now have the 2015 certification. So most of you will be looking at your 2014 version, and if you don't know which one, then you can ask your EHR company which of the measures or the years should be applied to your certification, 2014 or 2015. And make sure they understand you're talking about MIPS and not about meaningful use. So you can pick your pace and choose a 90-day reporting period if you like, and so we can always fall back on that, but we'd like for you to start right now and see how high you can get those numbers, knowing that you can go ahead and choose a 90-day reporting period when it comes to October or November. There are bonus report credits received for public health reporting and for clinical data registry reporting measures. I know many of you will be glad, if you've attested for Medicare this year, you'll be glad to get rid of the public health and the registry reporting as a requirement. But right now, folks, you want to take advantage of it if it's cost effective, because there's some good bonus points there. So this is just a graphic that shows you if you had a 2015 certified EHR, or you had a 2014 and 2015 certified EHR, then you would use those for the 15 measures. Now, I have to tell you, quite frankly, we're a little concerned about this, because depending on when you upgrade to your 2015, you may be forced into the 2015 measures. So we want to be very careful. You want to know when that upgrade is happening to your system, when you will have to start tracking all 15 measures. And of course, what we recommend is, as soon as you can track 15 measures, track them. Don't be concerned if you don't have a 2015 certification yet. That's okay, but you need to be aware of when you get it. So please ask your EHR companies when they're going to do your 2015 certification upgrade, and try to nail that down so you can manage what it is that you're going to have to do. So this is a look at the 15 original measures. And I have to tell you that these are very similar, if not the same, as meaningful use stage 3 measures. So we're not going to spend a great deal of time talking about each of these measures today. We could spend a whole session on that. I could absolutely spend the next 30 minutes talking about these measures. But what we do want to say to you is that you have base measures that are required. Now, we told you had a lot of flexibility, but the fact is, if it's a base measure, and there are 5 of them, then you absolutely have to do those to make any points in the ACI component. But they're not too bad. Provides the security risk assessment. We've been telling you about this for years. It's always been a requirement for meaningful use, but even more importantly, it's a HIPAA requirement. So your security risk analysis is a requirement that you absolutely have to do as a base score. E-prescribing. You have to do e-prescribing. You don't have to be at 60%. You don't have to be at 80%. You don't even have to be at 20%. But you have to have e-prescribed. If you have e-prescribed, then at least 1, or 3, I should say, we like to stick with that number 3, then you will pass the base score. You won't get many points after that if you're only at 3, but you will qualify and get some credit for ACI if you are doing all the base scores. Provide patient access. This is providing you patient portal. Again, it doesn't have to be 51%. It doesn't even have to be 25%. To qualify for the base score, you just have to have some score into the provide patient access component. So if you have 5 patients that are on the portal, you will get some points for that, and it will also cover your base score requirement. Send a summary of care record. My goodness, how we struggle with this one. This is under Health Information Exchange. Typically, we consider this using direct secure messaging to send and then to receive your continuity of care document. Many of you were lucky, and when we went to a 90-day reporting period for meaningful use, you got to exempt this because you had less than 100. I don't think, well, I do think that many of you might have less than 190 under 90 days, but you can't exempt it. Okay, you have to do at least, we're saying 3, just to be safe, you have to do some to meet the base score. If you don't meet the base requirements, you don't get any ACI points. So it is very important that over the next month or so, you contact your vendor, or you contact the Georgia Health Information Network, GHIN, our state HIE, or you contact us at Georgia-HITEC and let us give you some help on making this happen, because this has got to happen, and many of you are still not doing it. The next one is a new measure to us, the Accept or Request Summary of Care documents. So as you had been required for Meaningful Use to send your summary of care, your continuity of care document, now you're going to have to be able to request it and accept it or receive a summary of care document. And there are a couple methods to do this. Again, your state GHIN can provide you with a great deal of help here. Georgia-HITEC has a resource to assist you with this. So don't hesitate on this, folks. Get it figured out in the next month or two so you don't have to worry with it. Because it seems to me that most of y'all have ignored it for the last 2 years and been saved. But don't think that's going to happen this time, so you got to figure it out. These other requirements, patient education, you're familiar with. View, download, and transmit, you're familiar with. Secure messaging. Patient-generated health data is the data that you can get from a patient from their iWatches or some other device that they wear, or some other resource that they use to measure their health data. That's going to be interesting. Clinical information reconciliation. This is similar to medication reconciliation, but is expanded to include diagnoses and allergies. Don't think that one's going to be a problem for anybody. And then, of course, you've got your registry reporting, which will give you some extra points. So to summarize, your base score are those highlighted boldly or are in bold on this page. You have to accomplish the minimum base score, or you have to do each of these 5 in order to qualify for an ACI score. If you don't do all 5 of these, it is a 0. So we didn't quite get rid of the all or nothing, but it's much more flexible because, again, it's not over 50% for Patient Portal. It's just, did you have it? Can you prove it? So now that I've beat those up, I've got a slide that shows you what I just said. Sorry, I should have progressed to this next slide. This does cover the base measures I just discussed. If you can do, and we recommend 3 e-prescribes, 3 patient portals. You'll see that those have numerator and denominators. Send at least 3 summary of care documents and receive at least 3. The security risk assessment is still a yes/no question. And if you do that, you will get 50% of your base, 50% of your ACI score. So, folks, that's a pretty easy win to get 50% of a score. Okay? That's if you were in school, that wouldn't be a passing score, but the rest is fairly easy to bring up. Again, at this point for base score, the percentage that you had does not come into play. Just the fact that you've done it. As we move to performance, the percentage comes into play. So the performance score measures can equal 90%. And some of y'all are sitting going 50% and 90%. Wait a minute, that doesn't equal 100%. And we'll work that out for you in just a minute. Because you can score over the maximum, you'll just get credit for the maximum number. But if you score higher than the maximum, that's great. You're going to get a great reimbursement probably. So, the measures for the performance score are the ones that you see on the screen. Some of them are part of the bonus of the base score. And again, at the base score level, you didn't care about the denominator and numerator. You just had to have done it. For performance score, then the numerator and denominator do matter. Because if you have a 75 percentage, you're going to have a better score than somebody that's at 51%. And if you have a better score, you're probably going to get a higher reimbursement. And that is the net of the performance score. The higher your performance, the better your overall score is going to be. So although there's not a threshold, we'd like for all of you to aim for 99%. I'm not going to say 100%. That'd just be crazy. But if you get to 100%, many of you do have 100% this year, then that would be wonderful. Also, there's a bonus score if you report 1 or more public health and clinical data registries. So that's pretty good. And then if you report improvement activities using a certified EHR, you will get you will get more points. Okay, so it all kind of ties in there together, and the more you work on it, the more you'll realize that this looks complicated, but it's really more simple than it seems. Now, we're just going to briefly go back and visit what most of you will be doing this year, which is utilizing 2014 Certified EHR Technology to use the transition measures. And there are 11 of those measures. And again, most of you that I talk to do have a 2014 certified system right now. Very few of you have a 2015 system, if any. Now, again, we have a base score where the performance or the percentage is not critical, and those are your security risk analysis, your e-prescribe, your patient access, which is your portal, and send and receive, the continuity of care, the summary of care document. Not much different than what we just looked at. However, you'll notice that some of the patient engagement requirements, as far as personal health data, is not a requirement in the transition ACI components. The medication reconciliation is the reconciliation requirement rather than adding it to the new expanded reconciliation requirement. And y'all have all been doing that or should have. Patient-specific education, secure messaging, and then your registries. So this is much more condensed than the other, the 15 measures that we looked at. However, and some of the ones that are new are the ones that have been removed. And that's because your 2014 certified system doesn't have the ability to collect that data yet, or it hasn't been released and upgraded to your system yet. So the base score, security risk analysis, e-prescribe, provide patient access, and then send and receive for health information exchange. There's no minimum and maximum. You don't have to have 50% for the base score. We're recommending at least 3. So you just have to have done the yes-no questions and gotten that risk analysis done, and you will receive the 50% of the base score of your score for the base. Folks, that's pretty easy, except for that health information exchange component that so very few of you are doing that now. And what I do have to say is the more of you that do it, the easier it'll be for everybody to meet. So please, contact one of your resources. Well, I know we have some folks that are out of state, so if you are out of state, then please contact your health information exchange or your vendor about doing your direct. But please get that worked out in the next 2 months, please. Now for your performance score, you see that again the performance score is worth up to 90% or can be applied for 90% of your score. And this part is where the numerator and the denominator do make a difference. Because again, if you score 100% on your provide patient access, if you have 100% of your patients with access to the portal, you are really something, and I need to know who you are. But let's say, for example, you have 80, because I do know that there are some folks that have 80 or higher. If your score is 80% for provide patient access and most others are still at 50%, you're gonna bump your score up higher than other folks have. So this is a really opportunity. The sky is the limit, or the 100% is the limit, and the higher you get, the better your score is going to be. So let's all understand that anything is better than nothing, but the higher, the better. And then, of course, you do get the bonus scores for the registries and for the improvement activity. So, your opportunity for your bonus score. So if you're reporting one or more public health or clinical data registries like syndromic surveillance, which isn't an option in Georgia for our providers, and you don't get credit for an exclusion, there is no exclusion. But if you have a specialized registry, and some of you did pay for a specialized registry, now you can get some return on that investment because you can get a 5%, you can get a bump on this for your total score if you have one or more registries. And there's several different varieties of registries. We'll be glad to work on you and work with you individually. Some of you have access to free registries. Some of you are paying your EHR vendor or specific registry. And some of you don't know what a registry is. So this is something that we'd want to work through individually to see which one applied for you. Also, if you're using a certified EHR to report certain improvement activities, then you get a 10% bump. So these are kind of above and beyond, but again, they're not required. Okay? They are not required. And again, no exclusions per se. All right. So we just looked at a lot of information about the ACI scoring, but the net of it is you have a base score of up to 50 points. So if you get a base score, 50 points. You get a performance score of up to 90 points. You get you can get bonus points up to 15. And the composite score, all these added together. And if you go over 100, you're still only going to get 100. 100 is as good as you get. If you get 100, then you get 25 points in the ACI component. Let me say this again. You add these up for a maximum, and even if it's 120, it's only worth 100. We can only have 100. So if you're over 100, that's great. You still only get credit for 100. If you get 100 or higher, then you get full 25 points for this category. And now this is a scary slide, so y'all just stay calm with me, okay? This slide shows how you come up with this number, with this score. You'll notice under base score that protect health information and the objectives and measures, those 5 measures we talked about, if you can do all of those, regardless of what the percentage is, you get that 50 point. You get that 50%. Done. Done. And you can do that if you figure out that HIE component. Then we have these performance score pieces, and those are a little different. So if you look at patient electronic access, you'll notice that under it, it has a 9.5. When I first saw this, I was like, where does 9.5 come from? That doesn't make any sense. So we've got an example here in red to show you how we got the 9.5. Let's say your numerator for 90 days, and we'll just take that as an example. It could be your numerator for 120 days, could be your numerator for 365 days, because you can attest for anything between 90 and 365. But for this example, we're saying this numerator was 931 for a 90-day period in 2017. Your denominator, and again, folks, this is coming right off what you used to call your meaningful use report, dashboard, scorecard. You can look at this right now today to see how you're doing. Your denominator was 980. So 931 with a numerator 931 and a denominator of 980, that means you are at 95%. 95%. Now, I'm not sure I've ever seen anybody at 95% for patient portal access, but, you know, I made up the example, so I aimed high. 95%. If you have a 95%, that gives you 9.5 points. So you take the 95%, you divide it by 10, and you get 9.5. So it seems simple to me. I've worked it out several times. But if you take this slide and you look at it and think about it, I think it'll make a lot more sense to you. So, for example, the next one is 6.5. So this may have been a situation where their denominator was 980, and their numerator was closer to, closer to 650. And so it equaled 65%, and 65% equals 6.5 points. So if you go to your dashboard right now today and you do a report from January to today or yesterday, and you look at that report and you go to Patient Portal and it says for Patient Portal you're at 65%, that tells you you get 6.5 points. If for View, Download, and Transmit it tells you you're at 12%, you get 1.2 points. Period, end of sentence. It's easier than it seems. And as soon as you look at it a few times and we walk through it and make sure you're comfortable with it, then you'll understand how these work. So you get a percentage for every requirement. Okay, some of them may have zeros in them. You may choose not to do them. And as long as they're not a base score component, that will be all right. You can do that. You can choose not to do patient education, but you're not going to get a good score. It'll give you a 0, and we all know zeros weight down your overall score. So what we then do is we add up all these numbers to see what your total performance score was. In this situation, it was 36. You got 1 point or 1 percentage point for a registry. So what you got was you got a 10-point bump, which equals 1%, and your total performance score is 87.5. I know this is confusing. I promise you if we just go through it a few hundred more times, it'll be a piece of cake for you. But I do hope that if you go back and look at this slide and just study it, I think you'll have a eureka moment. It'll make a lot more sense. So I do want to tell you that there is a wonderful resource, the QPP resource, the Quality Payment Performance Payment Resource, that is available, made available through CMS, and it goes through most of this. It doesn't show you how the score is put together, but it does explain what the requirements are, what the exceptions are, or when you go one way and when you don't. And this is true for all the components for the Quality Payment Program or for MIPS. It's lovely. It's the best I've seen so far with the program. So very excited about that. You combine that with your other resources, you'll be in pretty good shape. And it just gives you somewhere to go look for answers that speaks clearly to it. Summary. First performance period, January 1 to December 31st. You have to start your program period by October 2nd, and you can pick your pace. We want everyone to aim for a full year, knowing that you can go back down to 90. We don't want anybody to take a 0. You can submit your data by the end of March 2018, and your initial payment adjustment will occur in 2019. And this could be a positive adjustment. Folks, there's a special set of money set aside for those that are exceptional and have over 70% total score, and you can do this. So I hope that that'll be the goal for most of you. To avoid a penalty, you must provide a report, one quality measure for one patient, or one improvement activity, or the base measures for ACI. If you do one of those things, then you will get a 0 penalty, 0 payment adjustment. That's the way it should be said, which, folks, is way flexible. I don't want any of y'all to do this. We can do much better than this and get a positive payment adjustment. To be eligible for a small bonus, you can choose to report for 90 days with 2 or more quality measures, more than 1 improvement activity, or the base measures and additional performance scores. And it is possible to get a pretty good score in a 90-day period, so we'll want to talk about that probably individually. So then we've got just a few minutes to talk about improvement activities. They account for 15% of your MIPS score. They are a new component. There are 9 categories and over 90 activities, and that website that was on that previous slide for the QPP site gives you all 90, and you can just go shopping, maybe pick out 5 or 6 that you want to do that are best suited to your practice, and then focus on 2 to 4 depending on what your requirements are. So you've got expanded practice access, which may be the times that you're open, your beneficiary engagement, achieving high health equity, emergency preparedness and response, Patient safety and practice assessment. Integrating behavioral health and mental health, that's a real hot button these days, folks. And it may be with your practice as well. Care coordination, which is very critical and a major focus on bundled payments and performance. Participation in an APM or population management. So if you go to that QPP site, it tells you which category the activities fall in, and you just kind of want to go shopping and see which categories look best for your practice and for your patients. You want to make sure you submit something, at least one improvement activity, regardless of the weight, because there are two weights. There's a high weight and a medium weight. I don't know what happened to a low weight. It's not there. But as long as you do one, then combined with participating at least for one for the other component, then that will be acceptable not to have a negative adjustment. You can choose one of the following combinations. You can have two high-weighted activities, one high-weighted, two medium-weighted, or you can have four medium-weighted. So you can mix up how you want to use these. Obviously, the high-weighted activities are a little more difficult, and you can do them for a partial year or a full year. So, for the patient-centered medical home model, if you are participating in patient-centered medical home, then you will get credit. And so for those of you that led the banner and did patient-centered medical home early, then you're in good shape. If you're considering doing patient-centered medical home, this might be a good time because it'll give you credit for it towards an improvement activity. As a matter of fact, that's what patient-centered medical home, it is full of improvement activities. If you have a group of 15 or less, or non-patient facing, or you're in a rural or health professional shortage area, then you only have to attest for 2 activities for a minimum of 90 days. If you're in an APM, you will get automatically full credit. So we need to look at everybody's situation and see where you fall to determine how many you need to do. I would still say pick out 6 and then let's back them back down as you can. And then, of course, there is the shared savings program track. I'm not going to spend much time on this, but that may give you credit for an APM and let you get full credit for this component without doing any additional work. It's worth 40 points. Mediums are worth 10. That's why we say if you do only mediums, you need 4 of them. 4 times 10 equals 40. If you do high, then you only need 2. 2 times 20 equals 40. So that's the way that works. If you're in a small, rural, or underserved practice, or non-patient facing clinician or group, then you don't have to do as many. So, or actually what they do is they double the weight. So if you do a 20-pointer, if you do a 10-pointer and you're in a small, rural, or underserved, then it counts as 20. So you only have to do 2 to hit 40 points. If you're in that environment, then you do 1 high and it counts as 40 points. They double the scores for you. So that is important, and that does minimize for those that are less than 15 or in rural, underserved environments. It gives you a lot more flexibility, but folks, don't take the low road. Aim high and just make sure you're covered, but do as good as you can, because in subsequent years, the scores are going to be compared. So the higher the score, the better you're going to compare, the more adjustment, the better the positive adjustment for you. And that's something we're going to have to work to get our hands around, because that's a new idea for us. So your improvement activities equal the total number of points scored. So if you did 4 medium weights and your practice is 16, you did 4 medium weights, you got 40 points. There's no percentage. You either did it or you didn't do it. So if you did it and you get 40 points, then you've made 100% on this particular one. So this one is much easier than it seems. We just got to pick the activities that best suit your practice and your patients. So you got to select your activities. You don't have to do more than 4, and then you need to document the improvement process. And that's something we may have to work on a little bit more, discussing a little more fully, because we have not been given the requirements for the documentation yet. And here is, again, the same site where you can go look at all those improvement activities. You can even pick the ones you want to try and put them into a report that you can print. This is very handy, and we recommend that you use this. Just go shopping here and see what works for you. So, what can you do to prepare now that I got 2 minutes? You need to find out what certification you have. Are you a 2014 certification or a 2015 certification? I will tell you that most of you are 2014. Does your EHR vendor support quality reporting? If you've been participating in PQRS, you should be in great shape on this. Now you can hopefully be a little more specific and pick quality measures that are best for your practice and patients, but you shouldn't have problems qualifying and hitting a good high mark with this one. Review your current improvement activities. What are you interested in? Review what's available. Decide what you're interested in and what applies. Review your meaningful use report, your PQRS report, your QRUR report. Most of your systems will generate these. Take a look at them. See what your numbers look like. If you're above 80%, you're in pretty good shape. If you're down in the teens, you need to do some work. Identify a qualified clinical data registry if there's one that is applicable to your practice. Again, we don't want you going spending a lot of money for a registry that isn't associated with your specialty or with your practice of medicine. See if you're exempt from MIPS. Do you have your low volume of Medicare Part Bs, or do you qualify for an advanced APM? That qualification is very limited right now. We've been told that it will be expanded in days and years to come, but right now that's very limited, and I think in another session we went over what these were, but there's very few of them, I think 8. Do you meet requirements for small, rural, non-patient-facing accommodations? So you need to see if you're part of one of those requirements. What else can you do? Well, you can call GA-HITEC for assistance. GA-HITEC and Alliant Quality are participating in the government contract for assistance. It is virtual assistance, so there may be a little bit more support that you will require from us. Get on every webinar you can. Get to the point where you could do the webinar. Then you will have learned everything you can that is available to you, and it'll be more clear the more you hear it. Initiate a community of care or community of practice with other practices in your community so you can get that direct, secure messaging taken care of, so y'all can work together on meeting these goals. I will tell you that it's much easier when there's somebody else that understands your situation and y'all can brainstorm how to accomplish these goals when you do it with a group. So we really recommend you do that. If you've got professional society resources, use them. There's a patient engagement playbook that's provided by the ONC. You may find that handy for your patient portal work. Participate in the Transforming Clinical Practice Initiative, or TCPI, which totally supports improvement activities. Or PCMH, which is a heavier lift, but it lets you bypass or get automatic credit for your improvement activities, which is pretty cool. Talk about which track is best for your practice, figure out what your risk is, and what's your greatest concern, and start now. Don't wait any longer. So this gives us, if anybody's left, polling questions. Do you believe you will need technical assistance in preparing for the MIPS program? Wow. Some of y'all don't need any help. That's cool. So many of you do think you will need some help. And so in the next weeks to come, those of us that are participating in the federal contract to provide assistance will be giving you some information and giving you some options on what kind of support you can receive and what areas we can focus on. So as you can see, we didn't leave any time for questions, but we'll hang on for just a little bit longer, see if we can answer any of them.
Thank you, Ms. Hanson. So you'll notice that you have the presenter Q&A pod. If you have any questions, whether they be individualized questions or questions that will be good for the whole, we ask you to submit them. If you have individualized questions, a representative from Georgia HITEC will follow up with you to address your concerns or to assist you in any way. But we'll just go through the questions. Also, you'll notice under the tech support chat pod, the presentation for today's webinar is linked. You can download it there. Additionally, at the beginning of the webinar, many respondents indicated that they wanted additional resources with MIPS, and Ms. Nelms did mention a previous Georgia HITEC webinar. That webinar can be found at the bottom right corner of your screen, and that will link you to the MIPS It Is About Quality webinar, which was presented by Georgia HITEC in November of 2016. And now we'll take questions.
Okay, so the first question that I see says the final rule stipulates a clinician being able to report a null value on e-prescribing. Will this result in a zero performance on the ACI category? What happens to providers who do not prescribe? So there has been, although they don't call it an exception and they don't call it an exclusion, they will make some exceptions. They basically, right now, we're saying they'll do it on a case-by-case basis, but you can contact the QPP folks, or you can contact CMS, and they can give you a pass, if you will, if you are not in an environment that prescribes. This is something that your non-patient facing providers will have to deal with, and there has been a method, a process set up to handle this. If you truly are in an environment that does not prescribe, then you can get a pass on this, if you will. So you will be okay as long as you follow the process and you are in an environment that's not expected to be prescribing. If you're in a situation where the doctor's seeing patients but somebody else is doing the prescribing, that's not going to work. So it would be in a situation, typically in a specialist that's not prescribing medications. But there is, I don't want to call it an exception or exclusion, but there is a process for this. So you should be covered. The next one, what would bump an EHR up to a 2015 cert versus 24? The 2015 certification is a full new upgrade. It's like when y'all were at before meaningful use and you upgraded to meaningful use. Or when you were in stage 1 and they released the modified stage 2 rules and you had to do another heavy lift upgrade to the stage 2 rules. This is not something that they should do without notifying you first, and it will, and when it occurs, then you should be able to see a scorecard that has all 15 of the MIPS ACI components to it. So this is not just a random upgrade that should happen. You should get a notification from your vendor making it very clear. We're asking you to be proactive. Contact your vendor. Ask when it's going to be done. In my opinion, I'd push it off as late as possible because I wouldn't want to have to combine the two and do 15. But that's just me. So ask your EHR company when they are going to be doing the 2015 certifications. We don't expect to see many for the next several months, but starting this summer, we do expect to start seeing those. And then we expect there to be some hiccups, just like there were with stage 1 and stage 2. So I need y'all to be prepared for that. But it should start happening within the next 6 months. Some of you are going to go the full year and not have it. Those, I worry that you're not going to have it for 2018 when you got to have it. So I'm a little concerned about that. Where can we go with assistance with public health reporting measures? Someone to help with a data plan or data analysis. So depending on what the public health reporting measure is, we have different services that would handle those. For instance, DPH might handle cancer registry. They handle immunization registry. They don't make syndromic surveillance available to you, but you no longer have to get that letter saying you can't do it. So you might go to DPH for those particular registries. You might connect. One of the best things, one we recommended the last 2 years, is go to your specialty organization. For instance, if you are internal medicine, go to your internal medicine professional organization and ask if they have a registry. And if they do, then see if that's something that you would like to participate in. Please be careful and don't sign up for a registry that's useless to you but costs you, $400 a month. So you do need to take a look at this. If this is something that you'd like some support with, then you can call Georgia-HITEC and we'll see if we can help you sort out what's available and what you want to try. The next one, what if your security risk analysis did not happen in your 90-day period? Does it count? Well, we're going to have to do some assuming here, and we're assuming that we're going to follow the same process we did for meaningful use, which means it has to be in the same calendar year. So you had to have done it in 2017, and you should have done it prior to or by the end of your 90-day period. So if you think the first of this year is your 90-day period, you best go ahead and do that security risk assessment immediately. But again, we're looking at existing rules around this, and that says that for 2017, you have to do that risk assessment in 2017, and you need to have it completed before the end of your attestation period. In theory, that means if you were doing a full year, you could do it in December. That means if you were doing a 90 days and it was October, November, December, you could do it in December. It means if you were using March, April, and May for your 90 days, December wouldn't work. Okay, that would be wrong. Okay, so hopefully that'll clarify that for you. The best thing is, go ahead and do it now. You do it in March, you don't have to worry. The next one is, what did you mean when you said in subsequent years the scores will be compared? That's an excellent question, and I wish I had another 30 minutes to go into this one. And this is why I'm so concerned about the cost component. So for 2017, you're really just, it feels like you're competing with yourself. You're just trying to get the highest scores you can. But the fact is that when someone gets a positive adjustment, someone else gets a negative adjustment. So if you get a +4, somebody else somewhere is losing or getting a -4. So you want to have as high a scores as you can, because if you've got an overall score of 69 and somebody has a score of 70, they might get the extra bump, and it'll minimize how much you get. So you're not just in this alone. Your scores are compared
because
to
this is a budget neutral program, right, Liz? And they're creating the benchmarks also based on what their data they're collecting early on.
Right, and it is budget neutral. However, there is a big pot of that's available for the first year to pay those that achieve over 70% in their total score. There's some extra money there to pay out to them. So you really want to get above 70%, and you really want to be as high as you can, because if there's somebody else higher than you, there's only so much money to distribute. And when it comes to cost, if your cost in your area is much higher than somebody else's cost in your area, you're going to lose points on the cost component, but not in 2017. And we'll go into more detail on that. If a clinician qualifies for exclusion for e-prescribing, y'all just love this. There is not an exclusion. There is not an exclusion for e-prescribe, no less than 100 prescripts. Does he still get 50 base points in the ACI? Folks, not doing enough e-prescribing, doing less than 100 is not the same as not e-prescribing. Okay, so if you do 5 e-prescribes, that's going to be part of your score, and that'll qualify. So if you do 1, you'll qualify for the base score. If you don't do at least 1, you're going to have to ask for some kind of special dispensation because you're non-patient facing or one of the other requirements. Okay, but the old exclusion for less than 100 prescriptions no longer exists when it comes to ACI. And thank you, Takasha. It is always my pleasure. If there aren't any other questions, or are there any other questions, I guess I could scroll down. Oh, that's cool. Must security risk assessment be performed annually? Excellent question. Yes, you must perform a security risk assessment annually, It is a HIPAA requirement. And you must have the dates of your risk assessment and mitigation plan must be updated. So don't turn in something that you call 2017 and then have your mitigation plan show 2016 dates. Not cool. Okay, and I think that's the last of the questions.
Here we have some resources, and again, the presentation will be emailed to you and it will be available immediately following the webinar so that you can access these resources. We thank you both, Ms. Nelms and Ms. Hansen, for an informative presentation. Again, we ask that you save the date, recognizing that March 21st will be a webinar on HIPAA and security risk analysis. Additionally, April 27th, we will host a privacy and security workshop where we will focus on creating effective HIPAA policies and procedures. On behalf of Georgia HITEC, we thank you for attending today's webinar. Again, you can access resources at www.ga-hitec.org. Those resources do include previous webinars in addition to today's webinar. And you can connect with us via social media at Georgia HITEC. We hope you have a wonderful afternoon.